morning, everyone. It's my pleasure as the president for the Ceylon College of Physicians 2023 to welcome you all for our specialty update on endocrinology, the last one for the year 2022. It's my pleasure to thank Dr. Chaminda Singh and the present president of Sri Lanka College of Endocrinologists for joining with us to conduct this meeting. So I thank all the presenters, the resource personnel for agreeing to do this. And I'll hand over to Dr. Madhuvanti Etiarachi to conduct the meeting here onwards on behalf of the Ceylon College of Physicians. Over to you, Madhuvanti.
Good morning. Welcome to another specialty update along with the Sri Lanka College of Ceylon College of Physicians and College of Endocrinologists. Today we'll have the first speaker, Dr. Dulani Kotachi. She'll be talking to us womb to tomb, essential tips to tackle women's health issues. Dr. Dulani, she's a consultant endocrinologist and senior lecturer, Faculty of Medicine, University of Kelaniya, and she has received Presidential Award in 2018 and Sri Lanka Medical Association and Hypertension Fernando Award for height measurements technique in osteoporosis patients in 2017. She has many publications to her credit, and she's the current chairman of the Sri Lanka Diabetes Federation in 2022 and current secretary of the Sri Lanka College of Endocrinologists for 2023. So over to you, Dulani, for your presentation and few housekeeping rules. We'll be having the questions at the end of each talk. So please, participants, you can please forward your questions to Q&A box. Once the talk is over, we'll be answering if the time permits. Thank you very much. Over to you, Dulani.
Good morning to all of you. So I'm the first batsman for this endocrinology update. So my topic today is going to be on womb to tomb, essential tips to tackle women's health issues. The reason why I chose this topic also because we speak very much less of women's health issues, and I thought this would be a good opportunity for especially the younger, the trainees, to know some tips how we can tackle women's issues. So a woman's life is anyway very complex, and so is her health. And I think in the modern day world, we have to think of women from small age to old age to avoid them from going into any complications in their life. So let me take a case. So this is a very common case. You and me see each other each day. So this is a 14-year-old girl presenting with weight gain, irregular menstrual cycles, hirsutism, and pigmentation around neck and axilla. So you can see this is a common presentation on the picture as well. So she has acanthosis, white stripe in abdomen, and her Federman-Galvez score is about 10. So for the trainees who doesn't know about the Federman-Galvez, so we have a score to look at the hirsutism, and it is scored from 0 to 4, and it's we have 9 areas in the body we can look at hirsutism, and we have to get the calculation from that. So this was 10, which is high. So she's a woman, she's a girl we commonly see with the common presentation. So the most common possibilities comes first. Polycystic ovary syndrome comes first when we think about a patient like this, but we shouldn't forget the other possibilities, whether it's a Cushing's, whether it's an androgen-producing tumor, this hypothyroid girl, whether she's having congenital adrenal hyperplasia. So it's very important secondary causes, the differential diagnosis we need to see. So we've seen patients who, just because of the typical presentation, thought of as PCOS and treated. So the tip here is we need to completely evaluate, if you see a patient like this, to exclude other secondary causes before labeling them as polycystic ovarian syndrome. We've seen realizing tumors, seen Cushing's in these younger categories of patients as well. So it's an essential tip you need to evaluate for secondary causes. So what kind of investigations can we do on her? So the panel of investigations we need to do is must do. We need to get her serum LH and FSH to look at the ratio. We have to do her testosterone levels, prolactin levels to exclude prolactinomas, especially even microprolactinomas because of the irregular cycles. TSH is important. And we need to exclude Cushing's as a screening test by doing overnight dexamethasone suppression test. And especially if the testosterone levels come as high, then we need to exclude congenital adrenal hyperplasia by doing 17-OHP. The stimulated test would be ideal. And we have to do her insulin levels, look for her glucose status by doing HbA1c or fasting blood sugar, and if necessary, doing OGTT. And it's a must we do an ultrasound scan pelvis to look at her ovaries. And one of the tips I need to tell you is we need to do these tests fasting in the morning. So it's time is important, and send your patients fasting. So we've seen patients do them evening, and they tend to even change sometimes. So make sure your patients go fasting for these tests. So these tests are done to exclude secondary causes. So how do we diagnose PCOS? So the Rotterdam criteria, there are few criteria, but commonly what we use Rotterdam criteria. So 2 out of 3 should be present. There should be clinical and biochemical features of hyperandrogenism, and there should be high menstrual irregularities and polycystic ovaries on ultrasonography, more than 12 antral follicles in one ovary, or the ovary volume should be more than 10. So even if you have 2 of them, it will be sufficient for you to have a diagnosis. So to come into the diagnosis, make sure you have excluded the secondary causes. Management, although it looks very simple here, it is not so, because we are seeing young girl probably stigmatized because of her facial appearance, bullied at school, and they are so shy and fearful of society, to face society. And every day in their life, they are hearing at their house about what they should be eating, about what they should be exercising. And when they come to us, they're fed up, they've had it. So we are managing teenage girls here, and tackling them is not easy. So my first tip for you in this is first counsel the family. You have to get family support, because you cannot have the rest of the family members having all sorts of enjoying all sorts of food and not giving her or not getting healthy food for others and getting her into a healthy diet. It's not going to be possible. So make sure your family is involved and they eat healthily as a family and do the necessary exercises, because we need to get the weight reduced to have a successful treatment at the end. So commonly we use the combined oral contraceptive pill, and the reason why we use it is to reduce LH and FSH levels, and also to reduce the sex hormone binding globulin levels, which can ultimately reduce the testosterone levels, which is the culprit hormone for this hyperandrogenism. So the place of metformin here is to reduce the insulin resistance. So especially important when young people are put on metformin and oral contraceptive pills. When they go home, their family members, sometimes their grandparents, are so worried that they are not given this proper treatment, saying it is a contraceptive, why are you giving this young person contraceptive? She might not conceive in the future. So all these myths about management, because are easy to prescribe, but you see so many discontinuations of treatment while they're on treatment for this. And we can use spironolactone, which is an anti-androgen agent, which is a non-specific androgen receptor blocker, which can reduce further the testosterone levels and reduce her hirsutism. So that is one of the ways. And the time duration we need to treat is different from each patient, but it takes about 6 months roughly to reduce their hair growth. And minimum time I would recommend would be 6 months, but most of our patients are on treatment for more than 6 months. And we have to monitor their scans, we have to monitor their testosterone levels, we have to monitor the electrolyte levels continuous. So it is a continuous process. Don't just write OCP, metformin, spironolactone, and okay, see you in 3 months. So they are bound to stop this treatment. So compliance is very important in these young people, because we are managing a whole family, not just a young teenager. Okay, so this patient now known patient with polycystic ovary syndrome. She gets married and she's now 25 and she has conceived. And she was diagnosed to have gestational diabetes at 26 weeks of POA. And she is at high risk because of polycystic ovary syndrome for gestational diabetes. So what are the implications of this mother being a gestational diabetic? One for fetal complications, the other is for maternal complications, because the fetal complications we see are not just for the duration of the pregnancy, but even postnatally, they are high risk of developing metabolic syndrome and diabetes. And during the pregnancy, they are more prone for macrosomia, they are more prone for developing placental insufficiencies, and then preeclampsia, and even postnatally, they can have complications. And maternal complications would be, again, the preeclampsia and especially the infections, which we see. So we need to control her gestational diabetes for the benefit of both the mother and the baby. So what about screening? This is kind of a dilemma currently all over the world, but we have to do a 2-hour oral glucose tolerance test to diagnose diabetes for people who have not been diagnosed with diabetes in the first trimester. And so it should be done at 24 to 28 weeks. And we have to use the criteria recommended by different societies, but commonly used criteria is IAD-PSG criteria that was according to the HAPO study about 10 years back. So what does this criteria say? If you do oral glucose tolerance test, the fasting blood sugar should be less than 92 to say it's normal. If it is more than 180 in 1 hour and 2 hour 153, we consider them either of this. If it's positive, we consider them to have gestational diabetes. But be aware that there are center-specific criteria. When you go into your obs ward, some obstetricians prefer nice guidelines, criteria, and Sri Lankan criteria might be a bit different as well, but this is the most commonly used criteria to diagnose gestational diabetes. You have to know the values in this. So how do we manage gestational diabetes? Mainly to achieve glycemic targets and maintain adequate maternal weight gain during pregnancy and to minimize the fetal outcomes. These are very important goals. So these glycemic targets are very important. Make sure, the tip is to tell your patient the targets, because now before pregnancy, we are used to 100 is normal, to our values 140 is normal. No. So during pregnancy, you have to tell the patient your targets goes down. So you have to have a fasting below 95. So usually in a normal pregnancy, we see around 60, and 1 hour postprandial should be 140, and 2 hour postprandial should be less than 120. So these are the targets we need to achieve during pregnancy to achieve an uncomplicated pregnancy. So this target should be told to the patient when you start treatment for these patients. Can we use HbA1c? Not for diagnosis, but we recommend HbA1c during treatment to see the response of treatment. And less than 6 is recommended as a good glycemic control. We should do it around 2nd to 3rd trimester. So how do you manage gestational diabetes? It's individualized, mainly the glucose monitoring, medical nutrition therapy, exercise, pharmacotherapy, weight management strategies, psychological support. So this is a multidisciplinary team effort to manage a gestational diabetic patient. And the tip is 80% of these patients are controlled with nutrition therapy alone. I think you know about the challenges in nutrition therapy, because this is a pregnant woman we are talking about, and they have cravings, and they have neighbors, they have friends giving all sort of food, and patients crave for them, and they are not very good at diet control sometimes. So explaining the consequences to the patient. I think education is the foremost thing why we are doing this with the patient and the baby, and especially regarding the well-being of the fetus. It's very important to tell the patient the risks involved in it. So they need to get into a proper healthy diet during pregnancy. So what about pharmacotherapy? How can we treat this woman? We can treat, if needed for treatment, we can start insulin, which is a preferred treatment. Metformin crosses the placenta, but it's not teratogenic. But there are risks of developing smaller neonates and from meta-analysis. and postnatally, they can accelerate the postnatal growth and higher childhood BMI. So that was a bit of a risk. So the newer guidelines, even 2023 ADA guidelines, does not recommend metformin as a first-line treatment, but there are situations, individual situations, where it is not preferable with the patient preference, and if it's possible to give insulin, then we can use metformin, but not any other hypoglycemic agent. And patients who are on metformin, like my patient in polycystic ovarian disease, and it's recommended to discontinue the treatment once they are pregnant because the benefit is not there anymore. So we can use insulins, especially the soluble insulin and the isoflurane insulin, as a basal bolus regime, and the long-acting analogs can be also used, especially the Detamir is recommended, approved from the FDA to be used for gestational diabetes. So how should we use these regimes? So when you have a patient with gestational diabetes, it is not so like a normal diabetic. We see them with blood sugar charts, blood sugar series. So we have to know how to tackle this blood sugar series. And when their after-meal sugars are high, then we can give a short-acting insulin prior to their meal, and we can adjust the doses accordingly to reach the targets. When their fasting blood sugars are high, we can give long-acting or intermediate-acting insulin to control their fasting. So this is a basal bolus regime, which has the highest efficacy in diabetic patients, more than the premixed twice-daily regimes. So my patient now is continuing. She has delivered, and she has now gone into her middle age, and she's 51 now, and she has ceased her menstruation for the last 12 months. And she's coming up with now features of menopause symptoms like hot flushes, mood swings, arthralgia. So this is a common presentation in, I think all of you must have had patients like this coming in the middle age with non-specific symptoms, and we need to attribute this to menopause. Should we? So a woman is considered postmenopausal when she's over the age of 45 and has gone at least 12 months without a spontaneous menstruation period. And the caveats here, if they have unusual symptoms, then we have to think of other reasons why they're amenorrheic. They could be having a prolactinoma, they could be having thyrotoxicosis, could be drug-induced. So many reasons we need to think of as well. But if they're unusually having symptoms, severe symptoms especially, please consider this. These are the caveats. And just thinking it's menopause is not going to help. But if it's you're not very sure, you can do, because biochemical testing is usually not recommended. It's a clinical diagnosis. But if you want to make sure it's clinical, especially in patients who have undergone a total abdominal hysterectomy, where they do not have menstrual cycles, then you can do an FSH level. A level more than 20 is considered to be a patient to be in menopause age. So commonly, these are the common symptoms we come up with in these patients. The vasomotor symptoms are the hot flushes, night sweats, crawling sensations on the skin. They're anxious, irritable, they are sleep disturbed, the issues with the memory, lessened concentrations, vaginal dryness, problems with the libido, they are fatigued all the time, with joint pains, and overall diminished well-being with depressive symptoms as well. So these are the commonly symptoms we see, and please don't ignore these symptoms when you see a person going into menopause. So how should we manage these menopause women? So I think this is important for the clinicians first to understand why we treat menopause, menopause symptoms, and for us to understand the safety of treatment as well. So where there are various estrogen formulations, we can prescribe for menopausal hormone therapy or the MHT. So if we add progesterone to it, for a woman who has intact uterus, then we can protect them from going into hyperplasia. And if they have intact uteri, we can only give them estrogen. So already we have discussed these patients, the benefits and risks of treatment options should be considered individually as individual patients. So benefits are more likely to outweigh risks if initiated for symptomatic women. before the age of 60. Usually MHT is not recommended after the age of 60, but there are individualized cases as well, as I said, but within 10 years after menopause. So this is kind of the age cutoff we give a treatment for MHT. And the risks of breast cancer, endometrial cancer has been evaluated so much. And there were some concerns with the Women Health Initiative, the research, where they came in about 10 years ago. But because of that, people were afraid that whether the breast cancer risks would be increased if you take MHT. But further on, later on, a lot of analysis went on to this research and found that breast cancer risks of a person taking MHT is similar to a person at that age without taking MHT. So there's no additional risk by taking hormonal therapy for breast cancer. But you have to select your patients correctly. So these are the available other options for treating menopausal symptoms. We can use estrogen, progesterone, the combinations, and we can use SERMs, and we can use tibolone, which is commonly used as well, and androgen therapies, especially for patients with problems with libido. These are the available treatment options and how we can use them. So who are contraindicated into this MHT therapy? Personal history of breast cancer, who has had venous thromboembolism, high risk for breast cancer, thrombosis or stroke, and in general, commencement of, as I said, hormone therapy is not recommended for women who are more than 60 years of age. So if you choose your patients correctly, with the benefits from this hormone treatment is far greater than the risks involved in it. So if the patient has contraindications and not decided to treat for vasomotor symptoms with the hormone therapy, then we can use the alternative therapy, especially selective serotonin reuptake inhibitors. The paroxetine, fluoxetine, escitalopram can be used, as well as the serotonin norepinephrine reuptake inhibitors, the venlafaxine and desvenlafaxine can be used. Occasionally we can use gabapentin and clonidine as well for the vasomotor symptoms. So there are alternatives. So please make sure your patients are symptom less during menopause, and they should not suffer because we are scared to treat them. We shouldn't be, and you should be thorough in your knowledge in treating these menopausal women. Should we screen them for osteoporosis? So estimated prevalence for osteoporosis in women aged 40 to 65 is low. So the mean, but there's a mean vertebral loss for about 6.4%, and the femoral neck BMD loss about 5% during the menopause transition. So it's a sudden drop. When you lose estrogen, it's a sudden drop of the bone mass. So who should be screened for osteoporosis? So there are some guidelines involved in it. So if a woman is in the age of 50 to 65 and with one major risk factor, and that is history of menopause prior to the age of 45, or a fragility fracture, or two minor risk factors, it's smoking and weight less than 57 kg, then they should be screened for osteoporosis using a DEXA scan. The strongest predictors for osteoporosis are the being postmenopausal and not using a hormonal therapy and the low BMI. So we need to make sure our patients doesn't go into osteoporosis during this transition, make sure their bone health is adequate. So my case is going to continue as the last case. So she's now 70 years and she's come up with a femoral neck fracture. And how should we care for her? So this is a common scenario. We started from polycystic ovary syndrome to gestational diabetes to menopause and osteoporosis, one of the commonest endocrine disorders we see in older age. And so diagnosis for osteoporosis, as you well know, is from the DEXA scan. So normal is a T-score of -1 and above. Osteopenia is a T-score between -1 to 2.5. Osteoporosis is T-score between -2.5, below 2.5. And we call them severe osteoporosis if they've had a fracture as well. So T-score is the number of STs above or below the average BMD value for young, normal adults of the same sex. So that is how we diagnose osteoporosis. But the most critical thing is we have fractures more commonly in the osteopenic range than the osteoporotic range. So if you do a DEXA scan, if your patient is in osteopenic range, please don't turn them away and say, okay, your your scan looks normal, you should not worry about it. They should worry when they're in osteopenia because they are at risk of fractures. So we should always look up for other secondary causes and do investigations appropriately to exclude other secondary causes as well. So we can do a risk assessment by using FRAC scoring system, and the 10-year risk fracture model can be used. So we can use the link, it's downloadable. There are separate one for Sri Lanka as well. So can use this FRAC score. So FRAC scoring is mainly used for patients who are they decide whether they need treatment, especially for osteopenic patients, whether they deserve treatment to prevent them from going into fractures. So this is a new threshold, new category of patients. We talk about the treatment thresholds. So treatment thresholds are different to country as well, and especially this is done to decide whether we need treatment. And Sri Lanka has different cutoff treatment thresholds. The major osteoporotic risk of more than 9% and hip fracture risk of more than 3% is considered to be needing treatment, not like the previous of 20 and 4, which we used in the worldwide category. So this is the 10-year probability of major osteoporotic risk fracture depending on the age. And not like beforehand, we don't just give treatment unless we know that they need treatment. They have come to treatment thresholds. And we can always use FDA-approved drugs to control this osteoporosis. And the most commonly used drugs are the bisphosphonates. And we have the alendronate and the zoledronic acid available. And the first line is the bisphosphonate, and which inhibits the bone resorption. This should be given to patients either orally or alendronate is given orally, and IV zoledronic is given IV. So oral treatment is either once a week, once a month. We have different preparations, and IV should be given once a year for 3 years. So this is the treatment protocols we have, and especially how long to give. Just don't write alendronate forever. So we have alendronate for 5 years treatment and zoledronic acid for 3 years, but we need to give a drug holiday depending on how their BMD has increased or decreased during that treatment period. So we need to reassess the fracture risk every 2 to 4 years, and we can give a drug holiday in between. That is mainly to prevent stretch fractures happening. Although we give bisphosphonates to prevent fractures, we can also make them go into stress fractures if we overtreat our patients, especially femoral shaft fractures. We need to give them calcium. Total daily intake of 1,200 milligrams of calcium per day, but we should not give it as a supplement more than 1,000. We should try to get them into good dietary calcium habits. So these are the calcium options available. And the vitamin D is very important. We need to keep the threshold of 30 nanograms per ml, roughly 75 nanomoles per liter, according to Endocrine Society guidelines. So we can often get this by ingesting 1,000 IU of vitamin D daily. But we should not be giving high doses intermittently in elderly people, which can increase their fall risk as well. These are the possible sources of vitamin D. How should we monitor these patients? So monitoring BMD by DEXA scans, either 1 to 3 years after treatment. And we can also measure their least significant change approach to see whether their BMD has increased during this treatment. And what we don't have in this country is the bone turnover markers, which is used extensively in other countries to look at the good response or poor response to treatment. That's a very useful bone turnover markers, the TTX and P1NP. So I've come to the end of my presentation. So I've talked about how women's health is important and what we should be looking at and the tips involved in managing these patients. Thank you.
Thank you very much, Dr. Dulani Kotachi, for that wonderful lecture. It's very informative also. We have one question. If a type 2 diabetes patient already on metformin becoming pregnant, do we have to discontinue metformin?
So that actually depends on the initial control. If they're well controlled on metformin, we would consider continuing that and without jeopardizing that initial control. Because where that is organogenesis is happening initial 4 to 8 weeks, we need to get their blood sugars under control. But if they're not, we can top off with insulin and then slowly discontinue. But as I said, in most South Asian countries with high insulin resistance, metformin is very useful. Although the Western guidelines do not recommend metformin due to various systemic research and the analysis. But still, I think South Asian countries do use metformin, and there's good evidence for metformin as well for this region of patients. So we would probably not discontinue.
With the time constraints, I would like to forward one question to you. What day of menstrual cycle should we do LH, FSH in suspected Pcos? So
there's no such thing because these patients have irregular cycles most of the time, and they've not had menstrual cycles for many months. So if they're not going into fertility, we can induce menstruation and then do at day 2 to day 5. But in other young people, we can just do an LHS FSH. We will not, because we're looking at the ratio and whether the levels are high.
Actually, there are a few other questions also because of the time. I will forward to you. You can answer that in the question and answers if you can do that privately. Thank you very much, Dr. Dolani. And we would like to present the certificate of appreciation to Dr. Dolani Kotachi on behalf of Ceylon College of Physicians. It will be emailed to you in due course. Our next speaker is Dr. Kavinga Gunawardena. She's currently working as a consultant endocrinologist in District General Hospital Negombo. She previously worked in Kandy and Ratnapura as well. She has many publications to her credit, and she's an author of several international book chapters as well. And currently she's the treasurer of Sri Lanka College of Endocrinologists and a council member as well. Over to you, Dr. Kavinga Gunawardena, and she'll be talking to us on challenges in the management of hypercalcemia.
So good morning to all. I'll be over the next 25 minutes, I'll be talking to you on challenges in the management of hypercalcemia. So hypercalcemia is a common scenario. As clinicians, we see this all the time. So I'll be talking to you on different aspects where we meet challenges in the diagnosis and also in the management. The first bit is the clinical presentation. So patients can present with different clinical presentations, starting all the way from asymptomatic presentations to obtundation and even coma. Most patients will have these atypical type of presentations where they'll complain of fatigue, very subjective type of muscle weakness, musculoskeletal aches and pains, depression, thirst, and polyuria, and constipation. So these are very atypical common type of symptoms that can point you towards hypercalcemia. And also the presentation can vary depending on the onset. If it is an acute onset, the presentation can be different, whereas in a chronic hypercalcemia, the presentation can be a little bit more asymptomatic. And also, depending on the severity, the presentation too can vary. Mild hypercalcemia is defined as a calcium level of less than 3 millimoles per liter, where most patients are asymptomatic or may carry some non-specific symptoms. Moderate hypercalcemia is when the calcium is between 3 to 3.5. If it is chronic, the symptoms are usually well tolerated. However, if it is acute, the symptoms can be marked, where they have polyuria, polydipsia, they'll be dehydrated, anorexic, nauseated, they will have muscle weakness and changes in the sensorium. However, if it is severe of a calcium level of more than 3.5 millimoles, the symptoms will be progressive and most likely they will have symptoms of hypercalcemia. So when we try to manage a patient with hypercalcemia, it's very important to catch them with these symptoms to establish that. So when we try to establish hypercalcemia, there's always a debate about what to do, whether we should do corrected, total, or ionized hypercalcemia. So to shed some light on this point, let me just talk about this total calcium versus corrected calcium. So calcium is a bound cation. It is bound to albumin. 45% of it is bound to albumin, and 10% is bound to organic and inorganic anions. Organic anions such as citrates, inorganic anions such as phosphates bind calcium. So calcium is bound to anions as well as albumin. So, but less than half of it, about another 45%, is in the free form or the ionized form. So when you want to check the calcium, you can check this 45%, which is the free or the ionized form, which is the free level that can cross into your myocytes, into your skeletal muscles. We can check that. Or if you're checking the total, the whole amount, we can do a correction to your albumin levels, and this is called the corrected calcium levels. Both are valid, and I'll tell you in which circumstances you can find trouble. So when can the total calcium give you issues, where you have to be a little bit aware that the total calcium can be high or low? In these instances, your total calcium can be high, where you can have hyperalbuminemia. So you have high albumin levels, especially in athletes or people who consume very high protein diets. You may see patients who are now on keto diets, consuming a lot of proteins. And because of the high albumin levels, they can have a lot of bound calciums, and they can have high calcium levels or hypercalcemia. The same theory applies for patients who get their calcium reports done after applying a tourniquet. When you apply a tourniquet, there's a small dehydration happening in that area, and the albumin levels go up, and then you can have a transient hypercalcemia. That is why calcium should be taken without applying a tourniquet. In multiple myeloma, where there is a when there is paraproteinemia, the calcium levels can also go up. So this is not a false elevation. This is an elevation when the albumin level is high. What about low total calcium? That is when you have low albumin status, such as hepatic or renal disease. Then you will have low calcium levels because you have low albumin. When will the ionized calcium be different? This can happen when you have acid-base disorders, especially if you have a respiratory alkalosis. Now, what happens with calcium and binding of albumin is when you have acidosis, the binding of calcium to albumin is reduced. And when you have alkalosis, the binding of calcium to albumin is enhanced. So when you have respiratory alkalosis, for example, when there is hyperventilation, the alkalosis enhances the binding of calcium to albumin. And when there's more binding, the ionized calcium levels drop, and you have low ionized calcium. So if you check the ionized calcium in a patient who has hyperventilation or acute respiratory alkalosis, you will have hypocalcemia. And the same applies for patients with chronic metabolic acidosis, patients with CKD. In CKD, because of the acidosis, there's increased ionized calcium, but you know, in CKD patients, because of other issues, they will have low calcium levels. And when you correct the acidosis, this ionized calcium levels will further drop, and then you can even precipitate a tetanus. So it's important to know what happens in acidosis, what happens in alkalosis when you assess your ionized calcium levels. Right, now that we know what happens to your calcium levels in certain circumstances, and now that we've established your calciums, the second most important thing is if your patient has acute severe hypercalcemia, we have to treat that. What is defined as acute severe hypercalcemia? It is defined as a calcium level of more than 3.5 millimoles per liter, and regardless of symptoms, if the level is this high, we have to treat it. And we have to look for complications, especially cardiac complications. We have to see if your patient has any sinus bradycardias, any heart blocks, cardiac dysrhythmias, hypertension, pancreatic diseases, peptic ulcers, and so on. While you're monitoring for complications, the cornerstone in management of acute severe hypercalcemia is rehydration. The rehydration starts with intravenous normal saline. We have to be very generous with the fluids, 4 to 6 liters in the first 24 hours. Although you have to be mindful not to overload your patient, especially if the patient has fluid overload status, such as renal or heart failure, and also in the elderly. Rule of the thumb is to initiate with about 200 to 300 milliliters per hour, and then to monitor the urine output and to maintain it for about 100 to 150 ml per hour. While you're continuing your hydration, you can give your patients an intravenous bisphosphonate. The ideal intravenous bisphosphonate at the moment is IV zoledronic acid, 4 milligrams over 15 minutes. It is considered to be superior to pamidronate, which is another option. And this is especially so if the hypercalcemia was due to a malignancy. So these are the two main options. You start your patients who has acute severe hypercalcemia. However, there are secondary forms of management for acute severe hypercalcemia, and this depends on the etiology. If your patient has acute severe hypercalcemia due to vitamin D excess, we'll talk about this a little bit more in detail later on, due to a lymphoma or a granulomatous disease or vitamin D poisoning, a prednisolone or a steroid can be effective. Calcitonin, again, we'll talk about this next, can be very useful until the bisphosphonates start taking its action. A calcimimetic, cinacalcet, which blocks the calcium sensing receptor, can be useful if the etiology is due to increased parathyroid hormones, because calcimimetics block the parathyroid hormones. This is useful for patients who develop this acute severe hypercalcemia due to hyperparathyroidism or a parathyroid carcinoma. And of course, we can go for dialysis or an emergency parathyroidectomy. Let's talk a word or two about calcitonin. The calcitonin available to us is the salmon calcitonin, which is used as IM or subcutaneously. It can be used every 12 hours or 24 hours. It does work rapidly. It is very useful for the management of acute severe hypercalcemia. It lowers your calcium concentration by a maximum of 1 to 2 milligrams per deciliter, and it starts to work very quickly in about 4 to 6 hours. However, the limitation is that it only works in the first 48 hours because there's a tachyphylaxis where the receptors are saturated. So it does not give you an action after 48 hours or after any further increment in dosage. So how do we manage acute severe hypercalcemia? You can give the hydration with saline along with calcitonin, and this will reduce your calcium levels in the first 12 to 48 hours. And in the meantime, you can give a bisphosphonate, and this will take about 2 to 4 days for the nadir, for the best reduction of calcium to come along. And this will buy you time to look for the etiology and manage the etiology. So these molecules will help you to buy time till you sort out the etiology. And with this, ladies and gentlemen, we'll move on to our next step. We've established the hypercalcemia. We have managed the acute severe hypercalcemia. And now we have to look for the etiology of hypercalcemia. Right, now when we look for the etiology of hypercalcemia, because of the time constraints, I didn't want to talk about the whole pathophysiology of calcium metabolism, but these three organs are very important: the gut, the kidney, and the bones. So these three balance your calcium, and the main hormone that balances this is your parathyroid hormones. This is your parathyroid gland secreting of PTH. And when you look for the etiology can be PTH dependent or PTH mediated or completely PTH independent. So there are two groups. When you look at the etiology, they are either PTH driven or PTH independent. However, if you look at it, the main causes would be these two top ones. So the PTH-mediated ones are primary hyperparathyroidism, tertiary hyperparathyroidism. This is usually in patients with chronic kidney disease, or familial hypercalcemic hypocalciuria. I'll talk about all these three in little detail. If it is PTH independent, this is usually malignancies, chronic granulomatous diseases, vitamin D toxicity, medications, and others. However, these two, the top two ones, account for 90% of cases of hypercalcemia. So if you see a patient with hypercalcemia, most likely they will have one of these two. 90% of the chance is that. Right. So I'll take you through all of these. First, we'll start with FHH, the familial, or before that, we'll talk about parathyroid hormones. Being an endocrinologist, it's important to talk about the hormones. So parathyroid hormones are produced in the chief cells of the parathyroid glands. It's a polypeptide hormone. The important thing about parathyroid hormones is that it has a very short half-life of about 2 to 4 minutes. So when you want to check it, you have to check the intact PTH, and you have to contact your laboratory and check it very quickly. This is the chief cell of the parathyroid gland, and on that, and now this receptor is very sensitive to the calcium levels in the extracellular fluid. So when there is high levels of calcium in the extracellular fluid, your calcium sensing receptor senses this, and it stops the release of parathyroid hormones. So when there's more calcium, the PTH stops, and when there's less calcium, the PTH is released. This is important in understanding the further diseases that we are going to talk about. And this is a very interesting diagram where when we try to find the etiology, so if you look at the first set of diseases, the PTH mediated or the parathyroid gland mediated diseases, the primary, the tertiary, and the familial hypercalcemic, the PTH mediated ones, when you check your PTH levels in patients with hypercalcemia, they will have high PTH levels. So hypercalcemia with high PTH levels, these are your differential diagnoses. Primary hyperparathyroidism, tertiary hyperparathyroidism, familial hypercalcemic hypocalciuria. Then your second set, where you have hypercalcemia, but your PTH levels are low. Then your differential diagnoses are, is it a malignancy? Is it granulomatous diseases, vitamin D toxicity, medications, and other rare causes? So when you have a patient with hypercalcemia, check your PTH level. This will direct you towards the etiology. Right, now we'll talk about the PTH mediated. How do we evaluate? As I told you, we'll do the PTH level. It's going to be high. We'll do a phosphate level. It should be low or low normal. When you do a creatinine, if it is high, it points you more towards a tertiary hyperparathyroidism. Then the next investigation is a 24-hour urinary calcium to creatinine ratio, and this will actually point you towards a familial hypercalcemic hypocalciuria. I'll tell you more details. Right, now, what is this familial hypercalcemic hypocalciuria? This is an autosomal dominant type of a disorder, and this is again this calcium sensing receptor that I talked about. This calcium sensing receptor in these patients become insensitive to the extracellular fluid calcium. So the set point of the calcium sensing receptor is now desensitized. So you need more and more calcium to stop the secretion of PTH. Your calcium sensing receptor is now desensitized. So these patients will have mild hypercalcemia, and it's a normal state for them. They will run a little bit of a higher calcium, and they will have hypocalciuria with a normal PTH level, and this is normal. And how do we diagnose them? We ask them to do a 24-hour urinary collection for calcium and creatinine, and at the same time we take a blood sample for calcium and creatinine, and we calculate a calcium creatinine clearance ratio. The 24 urinary calcium times the serum creatinine and the serum calcium to the 24-hour urinary creatinine. Although it looks very technical, all you need is the 24-hour urinary calcium creatinine and the serum calcium creatinine. You put these two values and you get the ratio. So for patients who have a very low ratio of less than 0.01, then 80% of the time, it is most likely your patient is having familial hypercalcemic hypocalciuria. A patient is having hypercalcemia with low urine calcium. And if it is more than 0.02, that excludes the condition. And what is the management? There's no management. It's a normal condition. You just make sure that they don't undergo unnecessary neck exploration and parathyroidectomy. And of course, screen your family members and also advise them not to undergo surgery for their hypercalcemia. Right, a word on tertiary hyperparathyroidism. How does this happen? Tertiary hyperparathyroidism happens in patients with chronic kidney disease. In CKD, there is phosphate retention, and because of the phosphate retention, there is low vitamin D levels. This leads to hypocalcemia, and hypocalcemia causes activation of the calcium sensing receptor. Look how we keep coming back to the calcium sensing receptor, and when there's low calcium sensing receptor, your parathyroid gland is secreted more and more, and with the chronic stimulation of the parathyroid chief cells, the parathyroid gland proliferates, and with time, there is tertiary hyperparathyroidism. And how do we manage this? The first thing in management is to prevent this hypocalcemia-induced proliferation of your parathyroids, managing the hypocalcemia in CKD right from the start. However, if it has already developed, you manage your patient's hypercalcemia with dialysis. You can use calcium mimetics and of course go for parathyroidectomy, especially for patients who are planning transplantation. Right now, we've talked about familial hypercalcemia. We've talked about tertiary hyperparathyroidism. Before I go into the common one, the primary hyperparathyroidism, let me talk about the PTH-independent causes very quickly. Right, the malignancy-related hypercalcemia. Now, this accounts for about 20 to 30% of hypercalcemia. The common malignancies are breast, lung, and multiple myeloma. Malignancies often are clinically evident. When your patient comes with hypercalcemia, you will see underlying features of a malignancy in your patient. And hypercalcemia in any malignancy has a poor prognosis. It's a poor prognostic marker. In these patients, the PTH will be suppressed. The phosphate can be high, especially if there are bone metastases. The alkaline phosphatase will be high, and there will be hypercalciuria. And this is where their PTH is low. What are the mechanisms? There are three main mechanisms. There could be many more. The main mechanisms are, first, if there are bony osteolytic metastasis due to the with local release of cytokines, usually in breast CA with METs, multiple myeloma, and so on. The treatment is with bisphosphonates. There could be a tumor secretion of PTH-RP. This happens usually without even metastasis, and this is the humoral hypercalcemia of malignancy. This usually happens in squamous cell carcinomas, renal, bladder CAs, lymphomas, and chronic myeloid leukemias. We can also treat these patients with bisphosphonates. The third way of developing hypercalcemia in malignancy is the tumoral production of 1,25-dihydroxyvitamin D. This usually happens in lymphomas, Hodgkin's and non-Hodgkin's. This causes the increased absorption of calcium from the gut due to the increased levels of vitamin D production by the tumor cells. And this responds well to glucocorticoids, as I mentioned to you at the beginning. The second cause for PTH-independent hypercalcemia is chronic granulomatous disease. The commonest ones are sarcoidosis and tuberculosis. There's a whole set of granulomatous diseases, which you can always think when you see hypercalcemia and clinical features of these underlying diseases. And when you see that, you can always do your vitamin D levels. And if it is high, and if the patient has any one of the clinical features of these diseases, you can check for these. What happens here is the 25 hydroxylation happens in the liver. However, there is the 125 hydroxylation happens in the kidney. But when you have granulomatous diseases, this step, which is controlled by PTH, is lost. And the 125 hydroxylation happens in the granulomatous tissue. In the pathological tissue, the 125 hydroxylation happens. So there is no control in the production of the 125 vitamin D production. So this is why you will have loads and loads of 125 hydroxy vitamin D production and subsequently hypercalcemia. Right now, we've talked about the PTH independent ones. We've talked about some of the PTH mediated ones. Now we'll talk about the common one, the primary hyperparathyroidism. This is the last bit of the presentation. In primary hyperparathyroidism, you will have an elevated level of calcium with low phosphates, and your intact PTH levels will be elevated. If you check your patient's urinary calcium, you will see 40% of your patients will have elevated urinary calcium. This can be falsely normal if you have concurrent vitamin D deficiency, which is quite common in this country. The calcium creatinine ratio, which we do to exclude familial hypercalcemic hypocalciuria, will be more than 0.02. 0.02. And if you check your vitamin D levels, this is important because if it is low, it is important to correct it before you go for surgery. Now that we've established that this is hyperparathyroidism with hypercalcemia, there are certain investigations to look for other effects, especially if the bone has been affected. And this is important for our students. You look at the bones to see if there's osteitis fibrosa cystica, if there are pathological fractures. You can look at the BMD, and the kidney will have nephrolithiasis in about 4 to 15% of the cases. If you perform a DEXA scan, you see that PTH has a catabolic effect on cortical bones, and especially in the hip, the spine, and the distal forearm will show evidences of osteoporosis. And also you can look for complications of hypercalcemia, looking for features of bradycardia, heart block, and the cardiac dysrhythmias, as I mentioned before. So once you've established that this is hyperparathyroidism, we have to now do the second set of investigations, the localization. Now, localization seems to be the challenge in these patients. There is a whole armamentarium of investigations currently available to us, starting from high resolution ultrasonography to CT, MRI, and to nuclear imaging. Ultrasonography is quite a sensitive investigation, especially in the hands of an experienced ultrasonographist, and also if the radiographer has done a lot of investigations before, and if the machine is of good quality, you can have a sensitivity of about 65 to 85%, especially in adenomas. And it can be very useful if there is, if you want to take a biopsy or an FNAC, although if the patient has a multinodular goiter or if there's an ectopic gland, the sensitivity can come down. The CT can be also very useful, especially if there's an ectopic. You see, the parathyroid glands can have an ectopic location because they come out from the branchial pouches, and they're quite notorious to be of an ectopic location. The MRI too can be quite sensitive, especially if the glands are of ectopic location. Another important, interesting investigation in localizing is the sestamibi scans. They have about an 85 to 95% sensitivity in localizing. And although it is negative, if just because you get a negative sestamibi, that does not mean that one does not have hyperparathyroidism. When can you get a negative sestamibi? If you have hyperparathyroidism due to parathyroid hyperplasia. So there's not one adenoma, but all glands are hyperplastic. So you will have a negative sestamibi. Or if you have multiple adenomas, or if there are coexisting thyroid nodules, or if the patient is on a calcium channel blocker. So if you just have a look at this, you see that the sestamibi has been taken up by the thyroid, and you have a small uptake at the bottom. This can be the parathyroid, and with time, the thyroid gland loses the contrast, but the parathyroid retains it. So this is the parathyroid. So now we know this is the parathyroid adenoma, and this is a positive imaging. And in this case, the thyroid takes it. There is no parathyroid imaging, and this is a negative imaging. Although this is negative, this does not mean there is no hyperparathyroidism. It's just that we have not been able to localize with the sestamibi. Right, so the management is quite straightforward. Once you've localized, you ask your surgeons to go for surgery and to remove your parathyroid. The outcomes are quite good. Once you remove your parathyroid adenomas, your PTH or calcium phosphorate and the bone remodeling markers return to normal. There's dramatic improvement in the quality of life of your patients. In the interest of time, let me just summarize very quickly. We've talked about the clinical presentations of hypercalcemia. We've talked about establishing and how important it is to establish hypercalcemia, management of the acute severe hypercalcemia, and then moving on to how to establish the etiology. A word or two on parathyroid hormones, the calcium sensing receptors, and how the level of parathyroid hormones help you in identifying the etiology. Then I talked about the PTH mediated types of hyperparathyroidism, the familial hypercalcemic hypocalciuria, the tertiary hyperparathyroidism, and then the PTH independent, the malignancy related ones, the mechanisms, the chronic granulomatous diseases. Then finally, I've talked about the primary hyperparathyroidism, the imaging, and finally the surgery. I thank you all for your kind attention. I'm happy to take any questions, right?
Thank you very much, Dr. Kavinda Gunawardena, for that excellent lecture. And there are about 2 questions. With tourniquet, what will change ionized to total calcium?
It'll be your total calcium, because when you put the tourniquet, there'll be a small amount of dehydration, and with that, your albumin levels will go up. So when you put a tourniquet, usually it is your total calcium level that will go up.
Now, in renal impairment, when EGFR is less than 30 ml per minute, as we can't give zoledronic acid, can we use steroids for hypercalcemia? This is the question.
When you have CKD, you can do a correction for your renal, for your GFR, and if you can't give zoledronic acid, there is a place for steroids, but if it might not give you a good benefit, and usually it will take about 2 to 4 days for the steroids to act. But if there is no option, if you can't give a bisphosphonates, there is a place for steroids.
Okay, thank you very much. Because of the time, we'll move on to the next speaker. I would like to give the certificate of appreciation, Nalina. Yeah, and it will be emailed to you in due course. Our next speaker is Dr. Sonali Gunathilaka, currently working as a consultant endocrinologist in Norelia General Hospital. She has got special interest in bone-related endocrine disease and pituitary disorders, and she has contributed towards developing international and national guidelines and has got many publications to her credit. She'll be talking to us on practical approach to sodium disorders, case-based discussion. Over to you, Sonali. Thank you.
Thank you very much. I hope you can hear me. Okay. So my topic today is practical approach to disorders of sodium. So sodium balance it's a tight balance in our body with the body sodium and water. Everything in life is kind of a balance. So even in our body, the homeostasis of sodium is a tight balance which is governed by many factors, but importantly, hormones. So I'll discuss these topics through two cases. My first case is about a 64-year-old gentleman who has a past history of hypertension, diabetes, and ischemic heart disease, as well as hypothyroidism. He's an ex-smoker for 9 years, presented with fever and difficulty in breathing for 3 days duration, and body weakness and lethargy, with intermittent loose stools for 1 day's duration. Examination, he was found to have fever without any pallor or lymphadenopathy. He is urolomic and has basal bronchial breathing in right side. His GCS was normal and the rest of the examination is fine. And on investigations, importantly, he has raised CRP indicating an acute infection and found to have low sodium levels. We repeated the sodium levels and again it confirmed low level of 121 millimoles per liter, where the lower limit is usually 135. And X-ray confirms right lower zone consolidation. So when we have these kind of patients, it's important to evaluate these patients properly and treat accordingly, because hyponatremia is quite common. 30% of the hospital admissions do have hyponatremia. So it's important for us to know exactly what it is and how to do it. So the problems in this patient is right-sided basal pneumonia. It could be community-acquired pneumonia because he has loose stools as well. And underlying malignancy cannot be excluded because he's a male, 64-year ex-smoker. And second problem is hyponatremia. Hyponatremia is defined as sodium less than 135. And this could be due to many reasons. It could be due to infection or a malignancy, or he's losing sodium through GI tract, and could be medication associated because he has a lot of other comorbidities, and or maybe untreated or partially treated hypothyroidism. All these causes could be the reason for hyponatremia in our patient. So when we talk about the assessment, first thing we need to know is it a true hyponatremia or not? So how do we define this and what is the meaning of this? So there are osmotically active particles which can contribute to conditions that present as hyponatremia. So usually if the sodium is low, that contributes to osmolality, and as you see in the first row, so low sodium usually brings up low serum osmolality, and that we call hypotonic hyponatremia, and that is the usual hyponatremia we see. But sometimes, although the sodium is low, osmolality could be normal or high. That we call isotonic hyponatremia or hypertonic hyponatremia. Although we expect osmolality to be low, there are some osmotically active particles which may increase the osmolality of the blood. In these situations, the hyponatremia you see in a blood report is not a really true hyponatremia. So we sometimes call it pseudo-hyponatremia or isotonic or hypertonic hyponatremia. And these particles are usually triglycerides or extreme levels of cholesterols, proteins, paraproteins, or high levels of glucose or mannitol. So these act as osmotically active particles, and it's important to exclude these before going into the proper management of hyponatremia. Okay, the next step would be to identify what is the severity of hyponatremia. So biochemically, we classify it as mild, moderate, and severe. Severe is less than 125 millimole per liter, and that is when we expect most of the symptoms. But above 125, we do not, classically, patients do not present with symptoms unless the patient gets an acute hyponatremia, not a gradual one. The other way of identifying the severity is symptomatically, and especially when the sodium is low, patients get a lot of central nervous system related symptoms. So mild hyponatremia, mild symptomatically mild, we say when the patient does not have many main symptoms, and moderate to severe is when the patient has nausea, confusion, or headache, and severe we call it when the patient has vomiting, cardiorespiratory distress, or abnormal or deep somnolence, seizures, or coma. So as the symptoms progress, the severity increases. So it's important to know what the symptoms are because our management depends on this. And then the chronicity of hyponatremia is our third important point to assess. So if the onset of hyponatremia is less than 48 hours, and if we are quite sure about it, we call it acute hyponatremia. If we are not quite sure, or if the onset is more than 48 hours, we call it chronic hyponatremia. It's important to know this because in acute hyponatremia, the brain does not have enough time to adjust for this. So the patients do get a lot of symptoms, as well as since the brain has not adapted quite fast, we can do corrections quite fast. In chronic hyponatremia, brain has slowly adapted to the low level of sodium. So even when we correct it, we have to go very slow. Okay, back to my case. This patient, is it true hyponatremia or not? Well, his sodium is low, and we've done serum osmolality, which is also low. So hypotonic hyponatremia, so it is a true hyponatremia. Severity. This patient falls into biochemically severe group, but symptomatically he did not have any major CNS symptoms apart from just lethargy. So I classify it as mild symptomatically. Okay, and then chronicity. So the patient presents with 3 days history and diarrhea, loose stools for 1 day. I'm not quite sure when this happened because I'm not sure whether the patient has had low level of sodium to begin with because he's a hypertensive patient, probably was on thiazide, so you're not sure. Because of that, I would take it as more than 48 hours as chronic hyponatremia. And the causes, probably drug-induced, and there could be other causes like pneumonia, GI loss, or hypothyroidism in my patient. So what is the algorithm? First is to confirm hyponatremia, which I did, and then by any chance, if a patient has acute or severe symptomatic hyponatremia, the next important step is to treat it immediately. Well, my patient did not have acute or severe symptomatic hyponatremia, so I proceed with the rest of the investigations. But in such acute or severe symptomatic hyponatremia, please remember you need to treat immediately. Do not wait for all these investigations. So next one is to see whether it's true or not. It's serum osmolality, which I did. And then to see whether it's hypo or smaller hyponatremia or pseudo hyponatremia. Next step would be to identify urine osmolality. What is the urine osmolality? So urine osmolality could be less than 100 or more than 100. What does this mean? So if the sodium is low in the body, and if that means body in normal terms, it's kind of dilute. So we expect the body to conserve sodium by concentrating the urine. However, if the urine is also dilute, then something is happening. The blood is dilute as well as urine is dilute. So this brings up the diagnosis of primary polydipsia or beer photonemia. So this condition could be managed when we diagnose this from urine osmolality. But when the real pathology comes, the urine osmolality will be more than 100 with all the above ones that I discussed. So in my patient, sodium was 121 and osmolality was low to 60. So then we come through this pathway to true hyposmolar hyponatremia. And then I did the urine osmolality, which is 264. It is more than 100. Now I have to look for the cause. Okay, then the next step is to see what the fluid status of the patient is. Whether the patient is dehydrated, euvolumic, or hypervolumic. So if the patient is dehydrated, which means that fluid and more of sodium is lost through GI tract or renal tract. So if there's GI tract, obviously the urine tries to be concentrated and tries to take up the sodium. So urine sodium will be low. But if it is a renal loss, obviously kidneys lose sodium. So the urine sodium will be more than 30. If it is hypervolumic, You can obviously look for heart failure, liver failure, or renal failure. And if these conditions are not there and the patient is euvolumic, then there are few differential diagnoses that we need to think of. Primary adrenal insufficiency, hypothyroidism, or SIADH are the common ones. You may think, where does the cerebral salt wasting come? Well, it could come under dehydrated group or euvolumic group, but it is a very rare diagnosis. But these are the common ones. Okay, these are the findings in my patient, euvolumic, and TSH is normal, 9 AM cortisol was reassuring. So my concentration goes to SIADH. SIADH, if you see, is a spectrum with other differential diagnosis that I discussed. Depends on the serum osmolarity, urine sodium, and fractionated sodium excretion, but it's kind of a spectrum. There's no hard and fast one category totally separated from other. One needs to know this when we interpret. Okay, high level of ADH in the absence of normal physiological stimuli for its release is called SIADH. So there are so many causes, but commonly neurologic, any infection, tumor, trauma, or bleed in the cranium or spinal cord can lead to this. Any pulmonary condition can lead to this. And a lot of medications, especially antipsychotics, SSRIs, TCAs, and carbamazepines, those can lead to SIADH. And other rare causes like post-surgical and even pain can lead to SIADH. Okay, so sometimes it's a tricky diagnosis, but there are criteria which had been developed for SIADH diagnosis. So most of them, the essential criteria I have told: low osmolarity, increased serum osmolarity more than 100, euvolumia, sodium more than 30, and normal thyroid, adrenal, and pituitary diseases, normal renal functions, and patient not using diuretics. So this we have discussed. And there are some other supplementary criteria using uric acid, urea, sodium excretion, so on. But clinically, we might not be able to do all these. But if somebody really wants to treat and diagnose, well, failure to correct hyponatremia after normal saline and improvement of hyponatremia after fluid restriction could be used as supplementary criteria, which can be used in clinical, and we use it when we don't have many investigations. Okay, treatment of SIADH is fluid response. And you may see a good response in many of the patients if we have a proper diagnosis. So 59% do respond. Why don't others respond? Well, because not all SIADH patients do respond to fluid restriction, because it depends on how much the free water clearance and the sodium excretion is. So how to identify that? When we can do urine to serum electrolyte ratio, that is urine sodium to urine potassium divided by serum sodium. And if the ratio is less than 0.5, you know that there's high urine electrolyte free water. There's high amount of free water in the urine. So if you restrict water, then there would be a very good response. But if the ratio is more than 1, urine is already hypertonic. That is, urine electrolytes are high. So water restriction may not work very well. So you may go less than 500 ml per day restriction, but it is very difficult to adhere. Plus, you will have to use other treatment modalities. So second lines would be loop diuretics, oral salt, vaptans. And talking about vaptans, ADH receptor antagonists, and European guidelines do not recommend vaptans, but American guidelines do recommend in resistant cases. So it's a clinical decision that you have to take. And poor responders show high urine sodium and high urine osmolarities. So treatment of hyponatremia is treat acute and severe symptomatic hyponatremia as an emergency and identify and treat underlying cause and review medications. And then depends on the volume condition. If the patient is hypovolumic, then you have to resuscitate patient with the normal saline. Euvolumic hyponatremia, I discussed SIADH, and the rest of the causes you need to treat accordingly. Hypothyroidism, treat with thyroxine, medications you need to stop. Likewise, hypervolumic status like heart failure, renal failure, you need to again go for fluid restriction and need to use loop diuretics and vaptans if needed. You may identify the medications and also the fluids in hypovolemic hyponatremia that will respond quite fast. So one needs to be very cautious about the rise of the sodium in these conditions, because we need to avoid overcorrection of sodium to prevent osmotic demyelination of the brain or the pons. And target rise should be 8 to 10 millimoles per liter sodium rise per 24 hours. Okay, so in the same patient, if I change the values a little bit, if the patient presents with sodium of 109 with vomit and confusion and sleepiness, what would be my management? So this patient is having hypoosmotic hyponatremia, and it is severe now, biochemically severe as well as symptomatically, very severe, has a lot of CNS symptoms. So the duration, again, I would take as chronic because the history is not very clear. Causes would remain the same, but this is symptomatic severe hyponatremia. So this is a medical emergency. This has to be addressed quite rapidly. And how do we do? Severe symptomatic hyponatremia, you need to treat with 3% saline, 150 ml over 20 minutes, and then repeat sodium levels. And until you get a sodium rise of 5 millimole per liter from the baseline, you may repeat 3% sodium chloride, 150 ml boluses 3 times. And once the symptoms improve, you may stop the 3% sodium chloride and treat the cause. But if the symptoms are not being improved, then 3% sodium chloride infusion can be used until the symptoms improve, or sodium rise for 10 millimole per liter, or sodium reaches 130, a safe limit. Okay, we move on quickly for the case 2. It's a 32-year-old previously well lady presented with generalized ill head for 3 weeks, loss of weight, loss of appetite, polyuria, and polydipsia. Examination, a little bit thin lady, mild dehydration with pallor, and rest of the examination is normal. Well, you can see in the investigation, there's pancytopenia with high ESR, sodium is 160 with raised calcium. I think Kavinga spoke about calcium quite well. Importantly, chest X-ray shows bilateral hilar prominence. So the problems are polydipsia, polyuria, and raised sodium, which could be due to many reasons, and constitutional symptoms with pancytopenia, high calcium, and hilar prominence. Could be granulomatous disease, infiltrative disease, infections, or malignancy. Okay, so let's talk about differential diagnosis for polyuria and polydipsia. It could be diabetes, poorly controlled, or a patient who's using SGLT2 inhibitors. Blood glucose is raised. Raised blood glucose or urine glucose class indicates this kind of a diagnosis. But in my patients, the sugars were normal. Diabetes insipidus, either cranial or nephrogenic. Blood glucose is normal, but can have high sodium. Psychogenic DI or primary polydipsia, that will give rise to hyponatremia, not hypernatremia, but the patient will have polyuria and polydipsia. Diuretics and other conditions also can give rise to similar conditions. How about the differential diagnosis for hypernatremia? So sodium more than 145 is called hypernatremia. So diabetes mellitus with dehydration, something like HHS, would give rise to a hypernatremia that is due to osmotic diuresis. And diabetes insipidus again, or free water deficit loss or dehydration can concentrate the body sodium and then give rise to hypernatremia, like in diarrhea, vomiting, fistulas, or burns. And iatrogenic causes like drugs that we give can cause hypernatremia. So what's happening in my patient? She doesn't have sugars, so not on any medications or diuretics, and obviously she has high sodium, not hyponatremia, so not psychogenic DI, and the patient does not claim of any diarrhea, vomiting, or we can't find any evidence. So this leaves diabetes insipidus as my differential diagnosis. So if you take diabetes insipidus, that is to deal with ADH hormone. So posterior pituitary secretes ADH hormones. Actually, it is a hormone produced by hypothalamus and stored in the posterior pituitary, and then it releases depending on the body's osmolality. And then it comes to the nephron, and in the tubules, it will act on its receptor to reabsorb water. So that is the function of ADH. So if there's a problem in the secretion in the pituitary or the hypothalamus, that is a cranial problem. So we call it cranial DI, where the ADH is not secreted enough. Or if there's a problem in the receptor here in the nephron, where the ADH will not work properly, we call it nephrogenic DI. So when the ADH is not enough or not working properly, what will happen is nephron will not take up water and it will lose all the water through urine, and that's why we get polyuria. And as a result, we get polydipsia. So any cause in the hypothalamus, pituitary, or its stalk can give rise to this. And there are so many causes. Idiopathic is the commonest, but tumors, radiotherapy, infections, infiltrations, many apart from genetic causes can give rise to this. And you may see that posterior pituitary on MRI is seen as a bright spot for the PGs. Loss of this bright spot indicates that there's a problem in the posterior pituitary, and that highlights the pathologies in the posterior pituitary. Okay, in the other form, if the V2 receptor is resistant for ADH, then you will get something called nephrogenic DI. And there are a lot of causes like lithium, hypercalcemia, hypokalemia. Many of the causes will result in nephrogenic DI. So how we diagnose? We diagnose this by letting the patient deprive of water. So if we don't give water, if there's a problem in ADH, whether it's secretion or receptor problem, whatever we give, whether we give or not give water, the urine will be very, very dilute because there is a lot of water loss, and urine osmolality will be very low, less than 300. But if we give desmopressin or ADH, then the problem in cranial DI is loss of ADH. So if we give ADH, this urine can be concentrated. But in nephrogenic DI, however much ADH we give, the nephron is resistant. So the urine osmolality will not be concentrated. So this is how we diagnose the two entities. So in my patient, the urine osmolality is 98, which shows either cranial or nephrogenic DI. But when we give desmopressin, it shows a rise. So it is cranial DI. So cranial DI is usually treated with desmopressin, that is ADH hormone. Nephrogenic, we need a higher dose of desmopressin together with thiazido. Indomethacin is difficult to treat. So in treatment of hyponatremia, if the patient is very dehydrated, the first thing, or due to any losses of water in GI or renal, first thing is we need to treat the patient and replace the volume. So you can use normal saline classically. And then once the volume is repleted, then you may use hypotonic fluids per oral or IV. Euvolumic hyponatremia due to diabetes insipidus, I told you the management. And if there's volume overloaded, we can use water and diuretics. Again, avoid overcorrection of sodium because this will again lead to osmotic demyelination syndrome. And the target is 8 to 10 millimole per liter in 24 hours. So in my patient, so cranial diabetes insipidus, we tried to go to find the cause, and there was a thickened stalk on the MRI thing, giving an idea of infiltrative disorders, and there's some hypopituitarism. When evaluated the cause, ultimately it came as tuberculosis, infiltrating the bone marrow as well as lymph nodes and also the pituitary stalk. Okay, so in conclusion, I discussed with hyponatremia how to evaluate and diagnostic algorithms, and what SIADH is, and treatment of hyponatremia, and also management of acute severe hyponatremia. In hyponatremia, I discussed the differential diagnosis and about cranial and nephrogenic DI, and how to diagnose DI, as well as treatment of hyponatremia. I think I covered all the possible things during this period. Thank you very much.
Thank you, Dr. Sonali, for that very informative and very, that lecture, which is usually very helpful for the physicians also. And since there are no questions, I would like to ask a question. When you're correcting hyponatremia, acute severe hyponatremia, not acute, the chronic severe hyponatremia, which has to be sort of corrected quickly also, but not so quickly. What's the time frame?
So it's like this. If it is chronic, even though whether it's chronic or acute, if it is severe hyponatremia, the one that you mentioned, then it has to be IV correction followed by gradual correction. So if it is severe, that is symptomatically severe hyponatremia, should be corrected with IV 3% sodium chloride, because symptomatically severe means there are CNS issues. So whether it's acute or chronic. But I think your question is mainly on chronic, but not so severe, moderate kind of symptoms. So there's no time gap. There's no time limitation, but the target is mainly on the sodium rate of sodium correction. So if the patient is more prone to get osmotic demyelination syndrome, our targets go down. So it's 4 to 6 millimoles per liter per 24 hours. But if the patient is not so prone for osmotic demyelination syndrome, then our target is 8 to 10 millimoles per liter per day. So if the patient, for an example, if the patient is having 125 millimole per liter, then it would take about 1 day. So 120, probably 2 days. 115, maybe 3 days. So likewise, it's not about the duration, it's about the rate of correction in otherwise other patients apart from acute or chronic symptomatic patients. So in acute and chronic symptomatic patients, the duration means that you reach the target of 5 millimole per rise, which makes them in a stable state, which puts them from unstable hyponatremic state to stable hyponatremic state CNS wise. So that again is not a major duration, but usually we say the rise should be 1 millimole per liter per hour roughly. So I hope that gives an answer for you.
Yeah, thank you very much. Again, on behalf of Ceylon College of Physicians, we'd like to present you with the certificate of appreciation.
Thank you very much for giving me this opportunity.
We'll move on to the next speaker, the last speaker for the day, Dr. Mudita Veerakodi. She's currently working as a consultant endocrinologist at Teaching Hospital Karapitiya, and she worked previously at Kurunegala and Badula Hospital as well. She has contributed towards developing guidelines and has got many publications to her credit. And she'll be talking to us on secondary hypertension endocrine perspectives. Over to you, Dr. Dumita. Sorry, Dr. Mudita.
Thank you very much for that kind introduction. I'm the last batsman, and although you can see that there are 51 slides, I'm not going to use all of them. So secondary hypertension is from, as we all know, from a definable cause. And the incidence could be about 5 to 15%, but it again would depend on where you are. For example, in primary care, it's not so common, whereas if you come to a tertiary hospital, it would be more commoner than that. Why is it important? It is because if you treat the cause, you can cure the hypertension and also avoid the complications of using long-term medications. And we need to keep in mind that there might be simultaneous essential hypertension associated with secondary hypertension. So just because you treat the cause of the secondary hypertension, it doesn't mean that hypertension would always go away. And of course, there are a number of secondary causes for hypertension, which include renal, endocrine, cardiac, and drugs. And we are only going to concentrate about the endocrine aspects now. So what are the causes of secondary hypertension? So non-endocrine causes are actually a bit more commoner than endocrine causes. So the commonest would be renovascular disease and renal parenchymal disease, or drug or alcohol-induced or obstructive sleep apnea, which we tend to forget. And also things like coarctation of the aorta, which are of course not very common. But when you look at the endocrine causes, the commonest is primary aldosteronism. Now, we investigate a lot of patients for this in our usual day-to-day practice. It could also be a pheochromocytoma, Cushing's, acromegaly, hypo, as well as hyperthyroidism, as well as congenital adrenal hyperplasia. Right. So when would we suspect secondary hypertension? First, if it's drug-resistant hypertension. Now, we know what to define drug resistance. We have to show that the patient is compliant on the medication, and also that the patient is on at least 3 antihypertensives, and one of them would be a diuretic. So if the blood pressure is uncontrolled despite all this, we call it drug-resistant hypertension. So if a patient is presenting with drug-resistant hypertension, we need to strongly think about a secondary cause. And also, if the hypertension onset is very abrupt, and if the patient is less than 30 years of age, or even if it's a previously known hypertensive who now comes with exacerbation, we need to think of secondary causes. Also, if there is disproportionate target organ damage for the degree of hypertension. Now, this is common when there's primary hyperaldosteronism. So you would get a disproportionately high amount of cardiac damage in patients with primary hyperaldosteronism. So you need to always think about this when there is a disproportionate target organ damage. And also if there is accelerated or malignant hypertension, or if there is a recent onset diastolic hypertension in older adults, or if there is unprovoked or excessive hypokalemia, we need to think about this, right? So these are the various causes of endocrine causes of secondary hypertension. So what you see in your left-hand side are more common than what you see on your right-hand side, but we come across all these things in our practice. So I need to tell you a bit of a word about congenital adrenal hyperplasia. So the 17-alpha hydroxylase variety is the one that causes hypertension, but this is a bit uncommon. We usually get the 21-alpha hydroxylase deficiency, which is not associated with hypertension. And what you call apparent mineralocorticoid excess is a syndrome where it's autosomal recessive disease where you get a mutation in the beta hydroxylase gene. So now this hormone is enzyme is needed for degrading the active metabolites of the mineralocorticoid pathway. So cortisol and cortisone are degraded by this enzyme, and when it is not there, you get an elevation of this active metabolites causing hypertension. And also we got things like Giddle syndrome, pseudohypoaldosteronism, glucose resistance, and so these are all the small print ones which you would think of when you can't think of anything else. But the other things which you see on your left-hand side are more common. So most of the causes of endocrine hypertension are to do with adrenal pathology. It could be a mineralocorticoid excess, like in primary hyperaldosteronism or Cushing's syndrome, or these are all in the adrenal cortex, or it could be a pheochromocytoma where there is a problem with the adrenal medulla. So this is the pathway of aldosterone synthesis and angiotensin II synthesis. I don't think in the interest of time I need to discuss this. I just put this for your interest's sake. Right. So when you come across a patient with whom you suspect a mineralocorticoid excess, hypertension and hypokalemia, there could be several possibilities. So I think most of you are fully aware of what you need to do. You need to do paired aldosterone and renin ratio, and depending on that, we could categorize these patients into various groups. So some of our patients would have low renin and high aldosterone. So these are the patients with primary hyperaldosteronism. So they could be Conn syndrome, that is unilateral adrenal adenoma, or it could be bilateral adrenal hyperplasia. Or these patients also could be glucocorticoid remediable aldosteronism, or rarely things like adrenal carcinoma or unilateral adrenal hyperplasia. We could also have patients with high renin and high aldosterone, which is called secondary aldosteronism. And it could be things like are actually not related to, directly related, could be things that are not directly related to the adrenal cortex as well. So it could be renal artery stenosis or a renin secreting tumor. Or these patients could be having low renin, low aldosterone hypertension with mineralocorticoid access. So in this group, we get people like people with congenital adrenal hyperplasia. So as I said before, it's commonly the 17 alpha hydroxylase patients, or it could be the 11 beta hydroxylase patients as well. Those are also uncommon because normal 21 alpha hydroxylase deficiency patients would either have hypotension or they would be normotensive. Or it could be apparent mineralocorticoid excess, where you could get the autosomal recessive disease that I talked to you about, where there's a deficiency of 11 beta hydroxylase dehydrogenase, or it could be Liddle syndrome or licorice ingestion. So just because you do a renin level and aldosterone level, it doesn't always mean that it is primary hyperaldosteronism. Right. So this is the algorithm or the pathway that you do for hypertension and hypokalemia. Now, having said that, not all patients with primary hyperaldosteronism would have hypokalemia. I will discuss that with you a little bit later on. So you do a plasma renin activity. Nowadays, we do not do plasma renin levels. We do a plasma renin activity and plasma aldosterone concentration. Now, it's very important that you do the sample collection appropriately. That is what's very important to you. And I will tell you in my next few slides how we are going to do it. So when you do it, I mean, we do get these marginal elevations, which we are not worried about. So it's very important that you do them properly and they interpret them properly. So if the renin activity is raised and if the aldosterone concentration is raised, we would investigate for causes of secondary hyperaldosteronism like renovascular hypertension, diuretic use, renin secreting tumors, or any cause of malignant hypertension and coarctation of aorta. Whereas the plasma renin activity is low and the plasma aldosterone concentration is high, we will think of primary aldosteronism and all its associated causes. Now, having said that, you have to make sure that the renin activity is low and the aldosterone concentration is high. So the normal ratio would be like more than 20 or more than 555 in SI units with aldosterone concentration which is more than 15 nanograms per deciliter. So you really need to make sure that you're getting the plasma renin activity low and the aldosterone concentration high, because sometimes you might get a raised ratio, but either the renin activity is normal or the aldosterone concentration is normal. So then you cannot strongly think of primary hyperaldosteronism. You really have to have a raised aldosterone concentration and a low renin activity contributing to the raised aldosterone to renin ratio. And on the other hand, if you've got a low renin activity and a low aldosterone concentration, you investigate for other causes like congenital adrenal hyperplasia, exogenous mineralocorticoids, the osteocorticoid cerebral-producing tumor, Cushing's, and all these things. Right. So primary hyperaldosteronism, this is the commonest cause of endocrine hypertension. And as I said before, hypokalemia would only occur in about 37% of the patients. And it indicates that there is severe hyperaldosteronism. And the hypertension is moderate or severe or resistant. And there is a very high degree of target organ damage, which is more than what you would expect from the degree of hypertension. So that you need to keep in mind. And that is why it is important that you treat the cause rather than treat the hypertension, because it is shown that treating the cause, that is the primary hyperaldosteronism, would reverse some of the target organ damage. Right, so how common is it? So it is said that in moderate hypertension, about 88% of them would have primary hyperaldosteronism, whereas in patients with resistant hypertension, it could be as high as 23%. And in patients with hypertension and spontaneous hypokalemia, it is as common as 50%. So half of the patients with hypertension and hypokalemia would have primary hyperaldosteronism. So diagnosis, as I said before, it's straightforward. So you do a screening test and a confirmatory test. But having said that, nowadays, if the aldosterone to renin ratio is really high, you do not need to do a confirmatory test. And of course, then you would do a subtype classification. Right. So plasma aldosterone concentration to plasma renin activity. So the aldosterone is typically more than 20 and the renin activity is suppressed. So this is a mistake we make. That's why I keep on saying that you need to make sure that the aldosterone is raised and the renin activity is suppressed. Because sometimes if the aldosterone levels are normal and if still the renin activity is suppressed, you would still get a high aldosterone to renin ratio. Or on the other hand, if the plasma aldosterone concentration is raised, whereas the renin activity is normal, still you can get a raised aldosterone to renin ratio, but that is not correct. That is a arbitrary thing. So what you need to make sure is that you have a raised aldosterone concentration and a suppressed renin activity. So how you collect the sample is very important. It should be a morning sample. The patient should be ambulatory for at least 2 hours. That means the patient should be up and about and not lying in bed for at least 2 hours before testing. It should be paired. You cannot do aldosterone on one day and renin on another day. And then the other thing is you should process it immediately. You cannot store it, centrifuge it, and process it another day. So the laboratory should receive it as soon as possible. And serum potassium should be normalized. So if the patient is hyperkalemic, you should make sure that the potassium levels are normal before you do the test. And you should take off the interfering drugs, especially spironolactone. I will talk a bit more about the other medications that could interfere later on. And then if it's kind of a not so high test, you can do a confirmatory test like the saline infusion test or the fludrocortisone suppression test. Now, these are the easy tests to do. There are some other tests like captopril challenge test, which we do not do commonly. These 2 tests are the ones that we commonly do. And then after confirming, you go for a subtype classification, right? So which might be a CT or MRI or adrenal venous sampling, right? So there are lots of medications that would affect the aldosterone level and the renin level, and of course the aldosterone to renin ratio. So if you look at the medications like NSAIDs, beta blockers, and central alpha-2 agonists, they would reduce the aldosterone but reduce the renin more. So you could get a raised aldosterone to renin ratio, which is a false positive. So potassium, let's say hypokalemia would reduce the aldosterone and would not have a major effect on renin or would slightly raise the renin. So that again will would lower the aldosterone to renin ratio. So that's a false negative. So if at all, if possible at all times, you need to withhold these medications before you do the test. But having said that, let me go back. I think I have not put that slide. Right. So what is very important is to stop the real offending medications. Those are the spironolactones, amloride, triamterene, all those medications, we should take them off for at least 4 to 6 weeks. Whereas other medications like ACE inhibitors and beta blockers, if you can, you try to keep them off those medications for at least 2 weeks. the most important medications are the spironolactone, triamterene, and amiloride, that kind of medications, because sometimes there is a practical problem, because if you take off the patient all these medications, you might not be able to do control the blood pressure before doing the test. So the least interfering medications are verapamil, prazosin, hydrolysine, and so on. So sometimes you might have experienced that just by using these medications only, you will not be able to control the blood pressure before the test. So if possible, take off all the offending medications and start the patient on prazosin or verapamil, slow release or whatever. But if not, continue most of these medications except for spironolactone for at least 4 to 6 weeks. So now, after confirming primary aldosteronism, what do we do? So we need to go for a subtype classification. So you do adrenal CT, and depending on the CT, you have several options. So if you've got a unilateral hypodense nodule, which is more than 1 centimeters, and marked primary aldosteronism, if the patient is more than 40 years of age, you still consider adrenal venous sampling. Why is that? Because with age, when you're more than 40 years of age, there are still risks of detecting adrenal incidentaloma. So you might have primary aldosteronism, but the nodule you see is a incidentaloma. So those patients would need this invasive procedure called adrenal venous sampling. Whereas in younger patients, less than 40 years of age, if you've got a unilateral nodule, which is more than 1 centimeter, you do not need adrenal venous sampling because incidentalomas are not very common in this age group. So it's either unilateral hyperplasia or aldosterone producing adenoma. But on the other hand, when you do a CT, if you find that it is either normal or if it's micronodular or if it's got bilateral masses, there's high probability of aldosterone producing adenoma, you go for adrenal venous sampling. Otherwise, you consider that as idiopathic adrenal hyperplasia and go for pharmacological therapy. So why they have devised this algorithm is, as I said before, treating the cause rather than treating the hypertension per se has lasting effects on primary hyperaldosteronism, because if you treat the cause, some of the cardiac effects can be reduced or stopped. Whereas if you just treat the hypertension, that cannot happen. So therefore, at all times, we need to find out whether we are dealing with the aldosterone producing adenoma, whether we are dealing with unilateral hyperplasia, or whether we are dealing with bilateral hyperplasia. So therefore, that's why we place a high value on adrenal venous sampling in these patients. Now, this is an invasive procedure, but we still need to do that because we need to treat these patients appropriately. So management, I don't think I will have a lot of time to talk all of these things. So you can do a unilateral adrenalectomy. Laparoscopic is the best. And before the surgery, if you can give the patient spironolactone for 3 to 6 weeks, that is ideal. So this is either for adenoma or unilateral hyperplasia. So for other patients, you start on medical management with mineralocorticoid receptor antagonists. And you might need second-line drugs too. So pheochromocytoma, again, this is the typical picture. You get a sense of dread, choking, rapid heartbeat, wobbly legs, shaky, feeling faint, but all these things could happen in lots of other things as well. So you need to really exclude other things before thinking that this is a pheochromocytoma. And what are the causes of death in patients with pheo? So it could be a myocardial infarction, cerebrovascular incidents, arrhythmias, shock, renal failure, and so on. So it's very important that you diagnose these patients, and you have to keep in mind that about 20% are malignant. So when do we suspect a pheochromocytoma? So if the symptoms are paroxysmal, so it's very important that you get a proper history. If there is resistant hypertension, or if the patient develops hypertensive crisis during anesthesia, surgery, angiography, and all that. Or if you're strongly suspecting a familial syndrome, right? So MEN1, so some of the familial syndromes are this. You've got MEN2A, MEN2B, and familial medullary thyroid carcinoma, where you would not get a FIO. Right. So I'm not going to go into details of this in the interest of time. And this is MEN2B with the ganglioneuromatosis. And of course, you would also suspect in von Hippel-Lindau, where you've got all these retinal angiomas or cerebellar or spinal hemangiomas. And a significant proportion would have pheochromocytomas as well. Right. So what are the tests that we can do to detect? So you need to have a very high clinical suspicion before you do these tests, because these tests would have a lot of false positives and false negatives. So plasma phetanephrines, the sensitivity and the specificity are high, but in urinary metanephrines, they are higher. So you can see that the specificity is higher for urinary metanephrines than for plasma metanephrines. So if your suspicion is very strong, you do plasma, otherwise you do the urine. And urine catecholamines, that's what we do. The sensitivity and the specificity are both lower. And in urinary VMA, which we used to do previously before we managed to do the catecholamines, it's even lower. Sensitivity is about 65%, specificity is about 88%. So MRI, CT, almost the same sensitivity and the specificity, but MIBG scan is better, which we do not have in our country. Right. So when we evaluate, first thing, again, you need to discontinue the interfering medications. There's a whole list. You do not need to remember. The laboratory will give you the instructions. If the clinical suspicion is very high, you can do a 24-hour urine fractionated metanephrines or catecholamines, or you can even do the plasma. Because I said the plasma level, the sensitivity, specificity is slightly lower. But if the clinical suspicion is lower, you need to do the 24-hour urine fractionated metanephrines and normetanephrines rather than doing the serum. Right. So if the levels are normal, and if the clinical suspicion is very high, you need to recheck during a spell. And if still in a spell, so if in a spell these levels are normal, it's very unlikely that the patient is having a pheochromocytoma. Then you might need to think of other causes. So if they are raised, so raised means it's about 2-fold elevation above the upper limit of normal in urine catecholamines or urine metanephrines. You do the localization and not otherwise. So imaging you only do after biochemical confirmation like CT, MRI, MIBG, PET, and octreotide scan. So these are the typical CT findings of a FIO. So most would have a pre-contrast attenuation of more than 10 Hounsfield units, saying that it's not a simple adenoma. And most lesions would vigorously contrast enhance and have a less than 60% washout of contrast on delayed images. So the same reduction in washout can occur in malignancies also, but in pheochromocytomas also. So it's very important that you get a proper imaging where they comment about the Hounsfield units, where they comment about the enhancement, they comments about the washout after contrast, because sometimes unless you specifically ask the radiologist, they would not comment on all these things. And this is the MRI where it would show a hyperintensity on T28 images, and you would not need a contrast if you're doing an MRI, right? So management of FIO, I'm not going to talk much about because I think I'm running out of time. So you give alpha blockage, beta blockage, and there are targets that are pointed out for you to keep before you go for surgery. So it's very important that you block these people and manage these patients at least for about 2 weeks before you go for surgery, because otherwise the surgeons will have a problem. So I'm not going to talk about this, but important to follow up these patients lifelong because recurrences are common, right? And then finally Cushing. So we all know the features of Cushing. So they can come with endocrine hypertension, but generally you can see all the other Cushing's features and not just hypertension. It could be ACTH dependent or ACTH independent, and about more than 50% of the patients would have hypertension out of the Cushing's patient. So you do screening, confirmatory, and you look for the underlying etiology. So these are the various tests that you can do. So for screening, you could do overnight dexamethasone suppression test or 2 24-hour urinary free cortisol levels. And for confirmation, again, you can do a low dose test or midnight cortisol or late night cerebral cortisol. And to do the to see the underlying etiology, you do ACTH and high dose dexamethasone suppression test, CRH, or you also need to do some sort of imaging and also inferior petrosa sinus sampling when you cannot really find out a cause. Again, depending on the ACTH, you can decide how to investigate the patient further, whether if the ACTH is suppressed to less than 10, you do CT adrenals because it's most likely cortisol production from the adrenals, whereas if it's detectable, it doesn't need to be high. So if the ACTH is not suppressed, it means that it's ACTH dependent disease. So there you do test to see whether it's a pituitary disease or an ectopic disease. So you do a high dose dexamethasone suppression test, or you can do a CRH stimulation test, or you could do a MRI scan. And if you get a positive on MRI, you consider it's Cushing's disease, but if it's inconclusive, you need to go for inferior petrosa sinus sampling. And ideally, we need to give CRH and show a gradient, but even if you do not have CRH, you can still interpret the test. So I think I'm going to stop now. I think I've run out of time also, and I would be happy to answer any questions.
Thank you very much, Dr. Mudita, for that interesting lecture, and it's very informative as well. Because there are actually no questions also, and I would like to thank all 4 speakers on behalf of Ceylon College of Physicians for your amidst your busy schedules for sparing time. And I would like to thank Dr. Manilka Sumanatillaka for coordinating at the end of Sri Lanka College of Endocrinologists, and special thank to Dr. Mayumi, our pre-intern, and Mr. Nalina for your excellent tech support. Thank you very much.